Welcome, everyone. I'm Dan Catanacci, a GI medical oncologist, and I'm pleased to be able to chat with you today about some recent clinical trials that were presented at our annual meeting, the American Society of Clinical Oncology, or ASCO, a few weeks ago here in Chicago. And so the three studies we're going to be talking about are phase 3 studies called Armani, Renaissance, and the ESOPEC studies. So the way we're going to do this is I'm going to present each trial, but in between, pause for any questions that come up in the Q&A section, and go from there. And if there aren't a lot of questions, then I'll proceed on to the next study. So the Armani study is a study that's asking the question as to whether or not moving second-line therapy earlier from what is typically done, waiting until the first one stopped working, but rather just moving it earlier after just 3 months of getting first-line therapy and seeing if that helps. The second study is talking about for patients that have limited or oligometastatic, we call it, stage 4 gastroesophageal adenocarcinoma. Is a surgical intervention helpful to those patients? And that's called the Renaissance study, or also known as the FLOT5 study. And then finally, a very big study called the ESOPEC study, which was looking at patients with stage 2 and 3 cancers, asking the question of which of two standard strategies that have been adopted by oncologists is better, FLOT before and after surgery, or chemoradiation with the cross regimen before surgery. So we'll start then with the Armani study. So by way of background, of course, when a patient is newly diagnosed with gastric and esophageal adenocarcinoma, the first step is to always stage the cancer. And the staging is important because it then dictates what are the best therapies, as far as we know, in terms of their stage. And so this first abstract, Armani, is talking about patients that have been diagnosed with stage 4, which by definition means it's spread outside of a surgical field, or known as metastatic, or M1, or it has a local tumor that's invading into regional structures. Typically, this is more esophageal, that's invading into major blood vessels, for example, that make it not safe to remove, and so therefore not resectable. So this category, typically and generally, I say, is treated with therapies that are to try and control the cancer as long as possible, limiting side effects as best as possible, and with palliative intent. And so that has been shown here in this schema that I should refer you to a lot of videos that are on the Hope for Stomach Cancer YouTube channel about each of these topics that we're talking about and more here. And so this is sort of a mind map that one would use for newly diagnosed stage 4 patients, following patients through first-line therapy, where we talk about FOLFOX chemotherapy, or CAPOX, which is 5-FU and oxaliplatin, plus biomarker testing and giving a matched targeted therapy as appropriate, or all negative for biomarkers and getting just the chemotherapy. And going through second line when this first one stops working, where we talk about HER2 negative, particularly getting standard second line chemotherapy with a regimen called paclitaxel and ramucirumab, or Cyramza. You could also use a regimen called FOLFIRI with Cyramza. And importantly, there is this intermediate step, which we call first line maintenance therapy, where after anywhere between 3 to 6 months of the full chemo, one drops out the oxaliplatin and just stays on the 5-FU or capecitabine as a maintenance approach. And we'll go into one slide just to emphasize why we do that. The problem, though, is that even though we know we have effective therapies in second and later line, only about 50% of patients that start first-line therapy in large phase 3 studies actually go on and get second-line therapy. And so why is that? That is because sometimes the cancer can be quite aggressive and quickly growing, and to the point where a patient, their performance status, we call it, their strength, deteriorates relatively quickly to the point where we can't even safely start second line therapy. And so that's the whole point of this first study called Armani is what if we just push this earlier and not wait too long? So first, before we get to that, I just wanted to highlight what maintenance therapy is and why we do it. And so FOLFOX chemotherapy to start with after diagnosis, again, we say around 3 up to 6 months of therapy, and then dropping out the oxaliplatin, continuing on just with the one drug until there is a progression, which can be several months, if not even years later. But if and when there's progression, then the first thing one would consider is resuming the oxaliplatin and continuing with such a strategy of on and off oxaliplatin in order to limit the cumulative side effects of the oxaliplatin, which is called neuropathy. And so why would we and when would we do this? Well, we would consider doing maintenance therapy if a patient's doing really well with the first line chemotherapy with or without the matched targeted therapy, if appropriate, like trastuzumab, et cetera, Herceptin. But at the same time is developing oxaliplatin neuropathy, or there's a concern that the neuropathy, which might be mild at that point, may get worse. And so we want to prevent it from getting worse. So you would stop the oxaliplatin and stay on the maintenance 5-FU or capecitabine because you can afford to. Everything's stable and responding. In addition, if you're having other types of side effects like nausea, vomiting, fatigue that are being attributed to the chemo, usually that's from the oxaliplatin within this regimen. And so for the same reason, you would stop it as long as the cancer is at least stable. In addition to maintenance therapy with one of the two drugs, one could even consider a chemo holiday or a chemo-free interval, CFI here. And that's if things look really well after scans to the point where the physician feels like we can afford a 5 to 6 week break from everything and then reassess. And sometimes chemo-free intervals can go on for several months before we need to even resume any form of therapy. So maintenance therapy is important for a large group of patients that are doing well, but to limit side effects. And you may have heard me liken this to like a marathon. We're trying to run a marathon and we can't sprint the whole way. We can't go full blast with full chemo the whole time. Okay. And one of the pre-submitted questions was, how long can this go on for? How long can we keep doing this? And so the answer is a very long time, and in some cases, years and years. And I'll show you that on some of the survival curves that come up in a few slides. And so as long as it's working, as long as it's tolerable, then we think of us trying to convert an acute problem, something that could be problematic in the very short term, and converting it into a chronic condition that's controlled as long as you're on and off the treatments that are doing that for you. Okay. So, again, though, the problem is that only about half of patients get to next line therapy. So that's summarized here in this table where we have a lot of phase 3 studies that have been done recently in the last few years. And these studies are showing that only around 40% to 60% of patients are going on to get second line therapy. These are all first line therapy studies. And so I mentioned the reason for that likely is because cancer progresses quickly and they're not able to get to the next line. But I will point out that this may be physician dependent, and there is an art to knowing when the optimal time to switch to next line therapy is. For example, in a study that we did called Pangea, personalized antibodies for gastroesophageal adenocarcinoma, we had a near 90% rate of patients that were progressing on first-line therapy getting second-line therapy. So there is some expertise involved as well, and that's going to come up again at the end of this. So that sets the stage, though, for this phase 3 study that was presented at ASCO this year by Dr. Pietrantonio in this Italian group. Leave it to the Italians to call this study Armani. And so I put this picture of myself from years ago, just joking, but that's me putting it on top of their slide. So the Armani suit, and these also are my pictures, not theirs. And so the goal of the study was to assess whether introducing second-line therapy with paclitaxel and ramucirumab, which they called switch maintenance, was better than just doing what we normally do, which is first-line FOLFOX or CAPOX chemotherapy, and for 3 months, and then continuing on with that and using maintenance therapy like I just described, and to see if this had a difference in overall outcomes. And so when we're at our annual meetings and big trials like this are presented, they then invite one physician to come up and discuss and put this into context. And so in this case, it was Dr. Iboha who did that. And I took the slide from her just to show you what's going on, is that the control arm of the study was just continuing as normal, but the investigational arm of the study was moving second line therapy earlier. And so that's shown here, that patients that were HER2 negative with gastric or G-junction cancer would get 3 months of chemotherapy that they called induction chemotherapy before they enrolled in the study. And as long as they were at least stable, SD, stable disease, and of course, if it was responding, partial response or complete response, patients would be eligible. Patients were then randomized to be continuing with standard treatment with more chemotherapy, FOLFOX, CAPOX, for 3 more months, and then maintenance therapy with just the one drug, versus moving second line therapy earlier. And so, like with all clinical trials, there's a big list of criteria that have to be met for a patient to be eligible. And some of the key ones are listed here, like HER2 negative, I mentioned. Any adverse events or side effects from the lead-in induction chemo from the FOLFOX had to have been minimal. And importantly, as I mentioned, the cancer had to be at least stable after 3 months of that therapy. If it wasn't stable, then you wouldn't be eligible. And obviously, you'd be switching anyway to second line therapy. And so a critical question is, how many patients are still stable after 3 months of induction therapy, or how many have grown at that point? And depending on the study, it can range between as low as 5%, which would be my personal experience, to up to even 40% in some older clinical trials. And so there's a range there, but let me just show you, for example, this recent study, Keynote 859, which was a study looking at chemotherapy with FOLFOX or CAPOX with or without pembrolizumab. And you can see here in all the patients enrolled, irrespective of their PD-L1 score, the rate of progression at 3 months, 25% or so of patients had already experienced disease progression. These are progression-free survival curves. So every time the curve drops, someone has experienced cancer progression. And but at the same time, as you increase the threshold of PD-L1 scoring above 1 or above 10, you can see that the control rate is better, which we've always known that PD-L1 high tumors do well with immunotherapies. And so only about 90%, excuse me, about 10% of patients have had progression after 3 months. So again, those patients wouldn't be eligible for the Armani study. So what did the Armani show? Armani study showed that the progression-free survival, which was the primary endpoint, was better in patients that got early switch to second-line therapy with paclitaxel and ramucirumab versus the patients who just continued on first-line therapy, as would be standard. The medians, which remember means half of patients have had progression and half have not, are shown here of 6.6 months versus 3.5 months. But remember, we do have to add 3 more months on here because they got 3 months before of chemotherapy. So this is the progression time point from the time of diagnosis and starting therapy. And so the important thing I wanted to show here, though, is, and along the lines is, how long do I have to be on this therapy for, or first line therapy, is that in both arms, there's about 20% or so of patients that are still stable, have not had progression several years after diagnosis. And so one question would be is, for those particular patients, why would you switch to second line therapy early? They're still stable on first line therapy 2 years later. And so this is something to point out near the end of this. The next thing to point out is to say, this wasn't surprising as a result to most of us, because if you switch therapy to 2 new drugs that the cancer has not been treated with yet, you would expect them to be more effective than just staying on the same chemo in terms of keeping it under control. But the real question is, in the long run, does that matter in terms of survival? Because eventually these patients are going to be switching to second line. at least we should be trying to. Remember, 50% in big studies tend not to go to second line. And the whole point of moving it earlier is to make sure everyone gets it. And so the overall survival was also improved in the early second line therapy arm. And again, remember, we have to add 3 months to these medians. And so the median survival from diagnosis, you can see here, and it was improved modestly, a couple of months median, but across the board in these patients. Okay. So in addition to that, the response rate was nearly 20% with the switch maintenance versus, interestingly, if you stayed on FOLFOX or CAPOX chemo, you still had a chance after the first 3 months to continue to have shrinkage. And so this is an important point, is that these patients probably didn't need to switch to second line therapy yet. They're still doing really well and even having more response by continuing on the first line therapy. But the real difference was the disease control rate shown here, where there were more patients controlled by switching early to the second line. Okay. So this slide shows what percentage of patients went on to the next line therapy after they either in arm A stopped the paclitaxel and ramucirumab stopped working. So about 60% of patients went to the next line of therapy, their third therapy essentially, versus in the arm B, which was getting first line chemo, about 56, a little higher than other phase 3 studies, but still less than 45% of patients are going on to second line therapy. Then it tells you what patients got, and as you would expect, the patients that were in arm A who switched away from FOLFOX and CAPOX, a lot of those patients doubled back and got more of it because it never progressed on them. Some of them, obviously, the patients that were on FOLFOX and CAPOX didn't continue with that, and they switched mostly to second-line paclitaxel and ramucirumab, and both, whether it was their third therapy or their second therapy, a common regimen is also irinotecan-based therapies like FOLFIRI. So, as expected, a lot of patients, though, didn't get to second-line therapy in arm B. So now we put Armani's statistics into this chart, and you can see again, a lot of patients aren't getting next-line therapy, second-line therapy, even though we know it can be effective. So what was the cost of this benefit? The cost was that there's more side effect with switching to second-line therapy. Nothing unexpected. All side effects that are similar to what we saw in second-line studies with this regimen, but introducing it earlier during a time point when a lot of these patients in the control arm are on maintenance therapy, just 5-FU or capecitabine, you're getting more neuropathy, you're getting more low blood counts, you're getting more blood pressure issues and blood clots because of the ramucirumab. And so that's the cost of switching earlier. So the authors concluded that switching earlier to second-line therapy improved their progression-free survival and overall survival, but at the expense of higher side effect profile, but nothing unexpected from that perspective. And they acknowledge, though, that targeted therapeutic options like immunotherapy for high PD-L1 tumors and claudin therapy, eventually when it gets approved, isn't being evaluated here. None of these patients are getting these types of therapies. And so how applicable this is to those patients is a question. And so Dr. Yeboah, again, the discussant, brought that exact point up, in that there's a lot of established biomarkers, there's emerging biomarkers that encompass a lot of patients. And how does this play a role with their matched targeted therapies and their relatively even better outcomes in terms of switching away from these early and going to second line? We don't know, because these patients weren't treated with these targeted therapies in the Armani study. And so she conceded that earlier introduction of second-line therapy seemed to improve progression-free survival and overall survival with a little bit more side effect. And so the question always is, does this change practice across the board? And the answer, I agree with her conclusions that maybe in some patients, especially those that are biomarker negative, that don't have a good targeted therapy, but I would say more so in patients that you're worried that the first line therapy is just barely effective after those first 3 months. Like they're stable on scans, but there's a slow upward trending of tumor markers would be one example. Or there are some vague cancer-related symptoms that are coming on, like with peritoneal disease, vague symptoms, even though scans look stable. You don't want to wait too long, and you should switch them. But at the same time, I'm worried, as she was, of doing this in all patients. I showed you how some patients can be stable after years on first line therapy, and you're throwing away a good regimen too early for them. So why change if everything looks good? It can be like that for a long period of time, especially when you factor in targeted therapies and immunotherapies. But even in those who don't have good targeted therapies, triple negative, so to speak, they have good chemotherapy options that can keep them stable for a long period of time. And then I'll also point out that I'm sure this will come in a future meeting. The authors here haven't showed us the difference in outcome in patients who are doing really well with response on scans after those first 3 months on FOLFOX compared to those who are just barely stable. You would expect that these are the ones that it's helping most by switching early, and these ones probably not so much or not as much. So my key takeaways here are we don't want to change too early in the patients who are doing really well. But of course, we don't want to change too late, and we don't want to miss our window to get effective therapy and treat with the first line therapy too long. And so, again, as I pointed out at the very beginning of all this does rely on the experience of the physician and someone who's doing this a lot and knows this cancer well. And it also depends on the patient and on the family caregivers to report symptoms and subtleties like that, so the physician acknowledges that and factors that into their decision making, because sometimes our objective tests like scans and tumor markers, etc., are not as reliable, and we need to factor in like, oh, you're having worsening symptoms that are consistent with your cancer. I need to factor that in. So that is the Armani study. And I'm going to open up the Q&A and see if there are any questions, or pause here now. I think you can raise your hand if you do have questions to address any of the questions about switch maintenance, switching earlier from first line therapy right away to second line therapy. And it looks like right now there's no other questions other than the one that was pre-submitted.
We have one person from the audience who'd like to ask a question.
Okay.
Hi, can you hear me?
Yeah.
Okay, this is really, really easy. Can you just go back to the overall survival curve? I just missed it because I was driving. That's it.
Oh, don't get in an accident. Okay, so let me go backwards here. How do I go backwards?
Thanks. And also just to the hostess, the chat is disabled, so people can't just ask questions in chat, just FYI.
So where did you want me to go to?
I assume you had like some kind of survival curve.
Yeah.
Over. Thank you.
Did you have a specific question about it, or did we lose you?
Sorry, I was driving.
Okay.
So
Yeah,
I didn't have a chance to see it. But and then what do we add 3 months to? Is it red or blue where we add 3 months? Just
So these tables at the bottom that the authors presented are showing in the investigational arm, PAC-RAM, the median progression-free survival was 9.6 months, and in the control arm it was 6.5. But that's from the time of randomization. It doesn't include the 3 months before that of chemo for both arms. So you have to add.
Oh, okay.
You have to add 3 months to both of them. That's all I was saying. Excuse me, I said the wrong numbers. It was 6.6 and 3.5, and then you have to add 3 to that. And then similarly for overall survival, they're reporting the survival from the time of randomization, not including the 3 months before that they got the induction chemo. So both of these numbers have to have 3 months added to it, and that I done that for you up here. So the blue and the red are from the time of diagnosis starting first line therapy.
Thank you.
Okay, that's a good question though. And just to reiterate, the chat function's disabled, but you can use the bubbles right next to it, the Q&A, and type your question in there if you have one. Okay, so that's the Armani study, and it is an important study because I think it highlights that a lot of patients aren't getting active therapy in next line, and we don't want to miss that. And so in this, they went to the other extreme and switched everybody early and showed a survival advantage. But I think my conclusion at the end was that should be done in patients who are sort of just barely stable or slowly progressing, but sometimes kept on first-line therapy. They need to switch. Patients who are like having complete response don't need to go and switch to second-line therapy. I think most oncologists will agree with that statement. Okay, so next study that we'll talk about is called the Armani study, excuse me, the Renaissance study, or also known as the FLOT5 study. And so this study is for oligometastatic stage 4 disease. And so on our staging platform here, when we first newly diagnosed with our staging modalities, and we're putting into categorizing patients into different stages, the stage 4 setting, as I mentioned in the first abstract, typically is treated with systemic therapy, chemotherapy, immunotherapy, targeted therapies that go everywhere and address all the sites simultaneously. And so historically, surgery has not been routinely used there because in decades ago when that was tried, it was really not helping. In fact, it was detrimental to patients. And so it's not routinely offered for patients because it's not in their best interest. However, the question is, stage 4 disease is very heterogeneous. There's a lot of different factors that then ultimately relay into what a prognosis will be. And one of those factors is how extensive is the disease spread? Is it limited to just a little bit of the cancer that's spread in one spot or two spots that are visible on scans, or is it extensive and everything in between? And so the real lingering question has been, what about those limited oligometastatic disease patients? Can we convert them to and treat them in such a manner that's more aggressive with a surgery or other ablative things that we'll talk about, and try and get longer term control of the cancer, and even be off therapy like we would be in an earlier stage. So again, there are a lot of videos on the YouTube channel, and one of them is triplet chemotherapy versus doublet chemotherapy. And this is relevant here in this discussion. And so in general, for stage 4 disease, the recommendation is to give a 2-drug or doublet chemotherapy regimen with or without targeted therapies as appropriate. When would one use 3 drugs? One might use it when there is a lot of cancer and patients are really symptomatic from their cancer, and we really want to have a response to improve their symptoms. That might be one. And this is in strict contrast to earlier stage setting, which we're going to talk about in the last abstract, stage 2 and 3, called locally advanced, where we're giving 3-drug regimen because it's with curative intent. And so the reason why we even debate about 3 versus 2 is because usually when you add 3 drugs together, it's more effective. But the counterpoint is that there's a trade-off, and that comes with more side effects. And so in these 2 examples that I mentioned, there's justification. The patient's really symptomatic. We need to go hard and try and get some response, and then taper off to maintenance therapy if we can afford to. In the stage 2 and 3 setting, we're trying to cure a patient, and so patients and doctors are usually willing to accept a higher side effect profile to get to that point. But in the general stage 4 setting, where you're not in these situations, generally speaking, adding a 3rd drug doesn't usually translate into a large overall survival benefit, especially if you can get active therapies in later lines in tandem, like we just talked about with Armani, and 2nd line, 3rd line, and higher. So that brings us now to this in-between stage, so to speak, between stage 4 and heavy disease burden, or even just the general patient, and localized to stage 2 and 3 cancer, this in-between oligometastatic disease, where we might want to be going for more aggressive approach. So then it's justifying, let's go with bigger chemotherapy regimen to justify this and try and do as best as we can. So what is oligometastatic disease or limited disease? And this is a very important question that there's not a clear answer to. And I see this a lot on the chats and in our support groups, is like, why do some people get surgery in stage 4 and others don't? And so I think the next few slides might enlighten you as to the reason for that. So oligo in Greek means few or small. And in this scenario, we're talking about just a little bit of spread. And you can see on the image here where you have a primary tumor, say in the stomach, and then maybe just one liver spot and or one lung spot, for example, as opposed to 20 liver spots. But what we don't really know is when we're trying to define what this entity is how many sites is too many? Within one site, say the liver, how many spots is too many? Is it 4? Is it 3? Is it 1? Is it 10? Are all the sites of spread similar from one place to the other within the body? And the common sites of liver, peritoneum versus bone versus other, for example. So we don't know the answer to that. We don't know what is the optimal definition that would then lead us to improve outcomes for those patients with a more aggressive approach. But we do know a few things over the years and with our experience, and that is, and from data from clinical trials, and that is that the more spots or sites of involvement, the worse the prognosis. And so, but where along that spectrum should the line be drawn is the real unknown. We also know that some sites are actually worse prognosis than others in general. And that's, for example, we know that brain or peritoneal disease tend to do a little bit worse than patients that have spread to only lymph nodes or metastatic lymph nodes outside of the surgical field. We also know that there's characteristics of the cancer itself under the microscope, like signet rings, or other patient just characteristics like age and other comorbidities, we call it, or other medical problems, all factor in terms of how a patient might do over time. So the real question, though, again, is can patients, if we can agree upon what a criteria should be for oligometastatic disease, get more aggressive treatment with curative intent with either surgery and or ablative treatments like radiation? And this is sort of the million-dollar question and also comes up all the time in clinic and in our patient support groups. So with that, before we get to the FLOT5 Renaissance study, we need to know about the FLOT3 study, which was the preceding study that was run in the early 2010s and published in 2017. And this was a smaller phase 2 study, not randomized, and patients were stratified by their stage at diagnosis, and there were 3 possible treatments. The first treatment in Arm A were for patients that had stage 2 and 3 cancer, and they were treated with FLOT for 4 cycles, 2 months, then surgery, and then FLOT for 2 more months, as is now standard. But this again was a preceding study to the pivotal FLOT4 phase 3 clinical trial for stage 2 and 3 patients. In Arm C, the second possible treatment was for patients that were stage 4 but did not fit into the criteria of oligometastatic disease that I'll show you in a second. And these patients were treated as would be typically treated with stage 4 with systemic chemotherapy, but with FLOT, not with doublet chemotherapy. And then finally, the important arm, as it relates to what we're talking about here, was the Arm B, which was the oligometastatic disease, where patients that fit into that criteria, which are listed here, were given 4 cycles of FLOT. Then if they were still eligible, go to surgery and then get adjuvant after the surgery FLOT for up to 8 cycles. And so this definition of oligometastatic disease is listed here, and I'll just take you very quickly through it because this is a common question for patients, is like, am I oligometastatic or not? And so the answer will be here. 1, you could have spread to lymph nodes that are not regional, not right around the esophagus or stomach. They're distant in the abdomen, like para-aortic, around the aorta, intra-aortic cable, peripancreatic, mesenteric lymph nodes. These types of words you might see on your CAT scan report. And these are referred to as retroperitoneal lymph node metastases. And in the image here, you can see them lining along the blood vessels here. So these are way away from where the stomach and esophagus are and are considered metastatic lymph nodes. So if you had spread there, traditionally this would be called stage 4 and surgery would not be in the cards. In addition to that, as a site, you could have one incurable organ site, like say, for example, the liver, and it could be with or without involvement in these retroperitoneal lymph nodes. And that's important to point out, as I'll show in a second. Other criteria, you could have peritoneal disease for this study, but it could not be seen on scans because sometimes if it's really bad, you can see it on scans. You couldn't have visible ascites or symptoms from the peritoneal disease. And on diagnostic laparoscopy, it can't be extensive. This is a Japanese scoring system, but it's like the peritoneal carcinomatosis index or PCI score that more of you might be familiar with. And essentially, as far as I can tell, this is like a less than 6 number for PCI score to be eligible and called oligometastatic. And then there's other criteria that the investigators delineated, like if it is in the liver, you can't have 5 or more. It has to be 4 or less spots in the liver that are seen. You had to have a good performance status, strength, like doing your normal daily activity or just minimally decreased daily activity. Normal blood tests like alkaline phosphatase, which is often used as a measure of occult bone metastases if it's high. And then again, specific to peritoneal disease, you could have involvement in one or both ovaries, which is called Kuchenberg tumors, which is part of the peritoneal carcinomatosis problem. One or both adrenal glands, which sit here on top of the kidneys, or extra abdominal lymph nodes, different from our retroperitoneal lymph nodes, but rather supraclavicular lymph nodes. And so on the stomach here, where you see regional lymph nodes, these all come out with your surgery, even if you're stage 1 or 2 or 3. These lymph nodes and ones up in the neck, like supraclavicular lymph nodes, do not. And so if you go and removing all this stuff, you're leaving cancer behind, which we know is not a good thing. So I wanted to point out that these criteria are arbitrary. This is what these investigators came up with, 10, 15 years ago. And everyone's definition might be slightly different. And I will refer you to a video that I've put on a few days ago that shows other groups that have come up with more stringent, in some cases, some more lenient definitions of this. This consortium, the OMEC consortium, for example, would not call peritoneal disease oligometastatic disease for the purpose of this study. And they would not allow for both retroperitoneal disease involvement and an organ. It had to be one or the other, not both. So more stringent. And so just so you know that the definition is not agreed upon across the centers and trials. So regardless, what happened in this FLAT3 study? So again, there's the arm A, stage 2 and 3, arm C, more extensive, and then the arm B, which is the limited oligometastatic. You can see the breakdown of where patients' tumors started in the esophagus, G-junction, stomach, and the percentage of the patients. And you can see that, of course, none of the patients in arm A, the stage 2 and 3, had spread or known spread. And then you can see the sites of spread in arm B compared to arm C. Common places are the liver, 18%, lung, 17%. In this case, only 7% with peritoneal disease, but a lot of patients with lymph node only disease, 60%, and most are retroperitoneal. So what did this study show? The overall survival, not unexpectedly, was best among the stage 2 and 3 patients, and it was worst around the extensive disease stage 4 patients, and the median survival similar to what one would expect from stage 4. And the arm B was somewhere in the middle. And something I don't think I explicitly said right here is that the arm B patients are getting surgery or intended to get surgery after the first 2 months of chemo. And so it's tempting to say or conclude that, well, see, the surgery was better than arm C, which wasn't getting a surgery. But we have to remember that these patients are super selected. They're patients who have limited disease based on the criteria on the previous slide. So they have better prognosis to begin with. So the $100 million question is this survival curve reflective of just the fact that you've super selected people to have limited disease, and or is it from the intervention of surgery? So this study can't answer that question. It was more of an exploratory study because it's not randomized. All patients in this study were supposed to go to get surgery. On the right side, what you see, though, is that 40% of those 60 patients in arm B didn't get surgery, no surgery. And you can see that they did worse than the patients who did. Again, it's tempting to conclude now, well, see, surgery is better. Surgery did better, almost more than twice as good. But we have to ask, why didn't these patients get surgery? They were supposed to. This arm was not randomized. Everyone's supposed to be getting surgery. The answer is listed here, and it's very informative. Some patients, after the first 2 months of chemo, didn't have a good response, and some of them actually died while on chemo. Some patients went to exploratory surgery, but when they did, they were either found to be not resectable for whatever reason technically, and or incurable spots of spread that was not known until they were in there. And another one patient became inoperable in the interim of those 2 months for undeclared reason. But let's say, for example, they had a cardiac issue, then that would make them not safe to go to surgery. After those first 2 months of chemo, they're not eligible for surgery. There were a few patients who, despite being randomized or put into the category of oligometastatic disease and intended to go to surgery, chose not to. One, because they had such a good response to the flat, they decided not to go, and another patient refused for an undisclosed reason. Maybe these patients are the ones on the curve down here that are still doing really well. And so the point is that the reason why these patients did worse is because they're the worst patients in terms of prognosis and prognostic variables amongst the patients in the oligometastatic patient cohort. So the real lingering question is, for the patients in arm B that got through FLOT, that were doing well, that were able to get surgery and wanting to, was it the surgery that made them do so well, or was it because they went through all these bottleneck steps and now that's why they're doing well and the surgery didn't really contribute, it just they had surgery? And that's the unknown based on FLOT3. But it was pretty suggestive. Like, this is a pretty long survival curve, and so it was warranted to study in a more prospective randomized study. And so the last thing I'd say about FLOT3 is that what they did see also, as was expected, is that different sites within the body, lymph nodes, peritoneum, liver, have a different prognosis, even though they're all being treated the same way in arm B. Lymph node only disease tends to always do a little bit better than the others, something to really be aware of. And then, as I pointed out on the other slide, is based on these results, we still weren't really clear. Is this just because they're super selected patients that are getting through all these hurdles and now that's why they're doing well in the long run? Or is it because of the surgical intervention, or is it a bit of both? And how much of each is contributing to it? And that we needed this randomized FLOT5 study, or Renaissance phase 3 study. So that brings us to the study result from ASCO, presented by the German group who've done all these FLOT studies. And this is the schema, which is identical to the FLOT3 arm B study. So patients with histologically confirmed gastric or G-junction adenocarcinoma, and I'll take this time to address another pre-submitted question, which was, can neuroendocrine tumors or patients with mixed neuroendocrine and adenocarcinoma tumors be enrolled in these types of studies or treated similarly? And so the answer is tricky. First of all, there's different degrees of neuroendocrine involvement. So it's not uncommon to have predominantly adenocarcinoma with what the pathologist will say neuroendocrine features. That is not unusual. I see that maybe 10 to 20% of the time. Those patients would be eligible here. On the other hand, at the other extreme, you can have patients that are neuroendocrine only, and they wouldn't be eligible for this. Or you can have patients that are predominantly neuroendocrine that have an adenocarcinoma small subset. They wouldn't be eligible for this. So I hope that answers your question in that, and I'm not sure what your situation is, where on the spectrum it's involved, but typically it's adenocarcinoma or with small elements of neuroendocrine features that would be eligible. So in addition to that, obviously patients needed to have medically operable disease and technically operable based on imaging at diagnosis and fall into the oligomets criteria. And they could be controlled with either surgery and or locally ablative procedure like radiation. And they were not allowed to have prior chemo or prior tumor resection. So this trial was not eligible for patients who had an earlier stage sometime before, like stage 1, 2, or 3 years ago, and then recurred with oligomets. They wouldn't be allowed in this particular study. So patients were enrolled. They got 2 months of chemo. Patients who had progression or for whatever reason were not considered surgically eligible would then not be randomized. They would not be eligible for the study. And so all of those patients in the arm B of FLOT 3 that came off and didn't get surgery would now be excluded from the rest of the study. And so we're only doing the patients who have oligomets, get FLOT successfully, are still stable, and still eligible for surgery. Then they're randomized to standard of care, more systemic therapy, or surgery to address the primary tumor and metastatic sites, and then some adjuvant chemotherapy as tolerated, and to see if there is a difference. And so I'll point out here that they wanted to get 271 patients enrolled, but they only enrolled 182, and that's because the trial was slow accruing. And you might ask, well, how can that be? This is such a common scenario, and everyone wants to know the answer to that. But the answers would be that, first of all, patients had to qualify by oligometastatic criteria. So if it doesn't qualify based on that list, you wouldn't be eligible. And secondly, this is a surgery or no surgery type of studies are always challenging because some patients just want to get surgery no matter what, and they don't want to get randomized to not getting surgery. And on the flip side, some patients don't want to get surgery no matter what and don't want to get randomized to the surgery arm. So those types of patients won't enroll to such a study. So these are highly selected patients from that perspective of patients who were willing to just leave it up to chance that they're going to get it or not. And so that's always hard, and that's contributed to why there was a slower accrual. They wanted to get about 90 patients in each arm, and they got about 70, which is still impressive given the study design. But just so you know, that's what was happening. Okay. So the definition of oligomets was identical to the FLOT 3 study, so it's listed here, but I won't go into it again. And I will point out other people have different definitions that even more stringent than this one. The primary endpoint was, does this improve survival in patients that get the surgery versus not? And other important subgroup analysis like by tumor site, lymph node metastases versus peritoneal versus other. Quality of life. And then over here, I need to point this out because also in these types of studies, sometimes patients that are willing to go into this study and say, I will do whatever arm tells me to do, whatever arm I get randomized to. But then when they get into that arm, they change their mind. And so from an intention to treat perspective, the way we analyze the study is you're going to get put into the group that you got randomized to. Even if you got randomized to arm B, where you're supposed to just get chemo, if you get surgery, you're still going to be considered an arm B patient. And vice versa, if you get randomized to arm A and you're supposed to get surgery, but you choose not to, you're still going to be analyzed as if you were in arm A. That's the intention to treat analysis. But they also stipulated, we understand that this may change and there may be a flip from on both sides. And so we will also do an analysis of what patients actually got and see if that makes a difference, which makes a lot of sense. So again, I showed you the numbers of patients enrolled, and this study went on from 2016 to 2023, and the analysis was done just a few months ago. You can see here the age of patients, the percent of male, female, the percent that had performance status of 0-1, the location of the primary tumor, and the importance of randomization is that each of these may have prognostic value, like if you have a bad prognostic variable and it gets unevenly distributed to one side, that's not fair for that side. So randomization usually equally distributes these across both arms, which we see here that there's similar numbers of these in each side. Same thing for where the cancer spread to. The lymph nodes, peritoneum, you can see there's actually a high rate of peritoneal disease here in this study. Liver is the most common. And you can see here that it's evenly distributed across the different sites of spread. Same thing with what the cancer look like under the microscope. We know, for example, diffuse type does a little bit worse than non-diffuse, and so that's even relatively evenly distributed across the arms. So the discussant also mentioned that was the case, and that it was well balanced between the arms, but it's a very heterogeneous patient population, which we knew that we're including patients with peritoneal only disease, we're including patients with liver only metastases, we're including patients with lymph node only metastases. So we know they have different prognoses just inherently, but we've evenly distributed them across the arms. So now we are set up to ask the real question, which is, does surgery help these patients compared to just chemo? Because now everything else is equal. So what happened? So all patients, remember, got the first induction chemo of 4 cycles, and all patients got that. Then patients were randomized to arm A or B. And what we first note is that patients in arm A, the surgery arm, the completion of all the proposed therapy was lower than the completion in arm B, which is not a surprise. We know that these patients are going to surgery here. And so those patients have to recover, and many patients aren't able to recover, or certainly aren't able to get all of these other doses afterwards. So that's conclusion number 1, or observation number 1. Patients came off study at the end of therapy, and more patients completed all of the proposed or planned therapy in arm B, as I just showed you in the previous slide. More patients had progression, likely because they were stopping the chemotherapy in arm A, and there were more deaths during the therapy in the arm A because of postoperative complications I'll show you in the next slides. And so fewer patients in arm A went on to get next line therapy, which we just talked about with the Armani study, how important that is to get second line, third line. But if you can't, then that could be detrimental, and less patients went on to later line therapies in arm A. In the surgery, most patients had an attempted surgery in arm A. Only 6 didn't, 4 decided not to, and 2 had progression of their cancer even from the time of randomization to the time they needed to get the surgery. But the remainder went to surgery, and most of the patients who went to surgery got something removed. A resection was executed. Interestingly, as I was alluding to, even though arm B patients were not supposed to get surgery, 15 or 1/5 of them did. And this points out that, even though there's a trial and a protocol and we try to stay to it, always the patient's wishes are what's honored, and you can always change your mind. And what you're the most important thing, not the study. And so they did get surgery, and of the ones who went to surgery, all of them had something removed. Now, when I say something, the reason why I say something is that the idea, remember, of this study was to remove both the primary tumor and the metastatic sites. And so the top table is for patients that had retroperitoneal lymph nodes, metastases only, and the second table is for the rest of the patients. And so you can see here that for all the patients on both arms who actually went to surgery, only around 50% of them actually got both the primary tumor removed and the metastases. And most of the time that was because the primary tumor was removed, but not the metastatic site. And so the question that's obvious is, isn't that the whole point of this? Is we're supposed to be removing both and seeing if that helps? But the answer is, similar to in the flat 3 arm B, is that even though we want to do surgery, sometimes we can't. Sometimes the surgeon gets in there and sees, I cannot get this out, or there's more disease in here than I thought, and this is not a good idea. In addition to that, something that didn't specifically come up in the report of the abstract, but is possible, is that sometimes there may be needed to be 2 surgeries separated by some time, because you can't do both a liver resection and an esophagectomy, for example. And so you need to do them separately. And you start with the primary tumor, recover from it, and then go do the metastectomy of the liver, as an example. But in the interim, you're not getting chemo, and things could get worse and progress. And so that may be why the second surgery wasn't done, and you couldn't get to the second part of the plan. So that, and maybe patients' refusal and other things, we don't know the details of all of this, and we may learn that with future presentations. But in addition, I didn't mention earlier that they didn't report yet how many patients got ablative therapy with radiation. So some of these patients may have had surgery of their primary tumor and then radiation to the metastatic site, but we don't know that information yet. So of each of those possibilities, we don't know the breakdown, but that's why probably not everyone had both primary and metastatic sites removed. So the other important thing to note is that patients that went to surgery in both arms had a pretty high complication rate, 40% to 60%. And some patients had to go back and get revision of their surgery to fix new problems that emerged. And mortality after 30 days and after 90 days was quite high in the patients getting surgery. So what did this overall survival show? This is the punchline here, and that is in the intention to treat analysis. Remember, some of the arm B patients actually got surgery, but in the intention to treat analysis, the red curve is the patient who were in arm B that were supposed to just get chemo. And the blue curve are the patients who got surgery. And so what we see is a classic crossing of the curves where initially there's a lot of patients that are actually doing worse by having gone to surgery compared to just staying on chemo. And on the other side, there are some patients on the longer term that maybe it looks like it might be better than just staying on chemo. However, this far end of the curve is the most variable because there's only a few patients that have been followed that long to really be definitive. So we don't know. And ultimately, the overall survival statistics are that this is negative. So the discussant points out, as we know, is that 60% of patients have post-op complications. There's 80% 9-day mortality, 20% required resurgery, and that probably accounts for why they're doing worse. A lot of patients are doing worse. And in addition, a lot of patients aren't getting the chemo that they're supposed to be getting. And so for all those reasons, it seems to be detrimental to be in the flattened surgery arm, at least in a large proportion of the patients. So again, it's not fair if you're including surgery patients in the arm B. So the per protocol analysis switches those patients over to arm A and runs the analysis again. And you can see it's essentially the same. Maybe the detriment is a little muted. Maybe the benefit on the other side is a little bit better, but overall it's still statistically negative. And again, that we're not talking about a lot of patients that are contributing to this difference. And so unfortunately, the study is considered negative. Now, what about specific subgroups within the disease? There is the retroperitoneal lymph node only, there's the liver only, and there's the peritoneal only. And you can see that in all three of those categories, surgery arm tends to do worse, at least initially, and in peritoneal disease, across the board does worse compared to just staying on chemo without surgery. On the other hand, the flipping of the curves really happens mostly in the lymph node only disease. Again, small numbers of patients, but that's where it's happening. In a larger group, the liver, the most common subgroup, they're essentially superimposable, except for the detriment early on from postoperative complications. So overall, the study is considered negative, but there's a signal of benefit in lymph node only disease that probably should be studied further. And then I really want to point out that look how good the survivals are in both arms. They're above 2 years median. And that's more than double of classic stage 4 disease. So the light in all of this is that patients with limited oligometastatic disease do well, relatively speaking, do well. Like the 5-year survivals are anywhere between 20 and 30%. And so that's why we're always seeing patients doing well in this group, but it has nothing, unfortunately, to do with the surgery and the surgical intervention. So the conclusion was that the trial, even though previous trials showed benefit, now in a randomized study where we're seeing the parallel of what happens without surgery, it's because they just selected patients that do well, not because of the surgery. Now, that said, the retroperitoneal lymph node metastases only, there may be a signal of benefit there that future studies should focus on. And then peritoneal disease, which did worse with the surgery arm compared to just staying on chemo, I need to point out is that they didn't use HIPEC. They just went in and surgically removed stuff. So That's something to be noted. But ultimately, I think all of us agree that we need to study each of these independently. But the problem with that is that they're hard to accrue to even when we did this study letting everybody. Now, if you do a study just for peritoneal or just for retroperitoneal lymph nodes, it will be more challenging to accrue to and to get a good answer. And so ultimately, the final conclusion here, though, of Renaissance Flat 5 is that in these limited oligometastatic patient disease, it did not improve survival by doing surgery, probably because there was incomplete removal of all the known sites for the reasons we discussed, complications post-surgery, systemic therapy needing to be stopped that we know controls the cancer, all contributed to the negative overall result. I wanted to finish this second part with a positive note again, and that is that maybe the answer isn't surgery, but other ablative techniques that are less invasive, like radiation, where radiation has a lot less side effect than, say, surgery. It can control areas pretty well, maybe not as well as surgery, but probably when you factor in the post-operative complications, maybe overall would be better. And also ability to treat multiple different sites at the same time as opposed to surgery. And it won't require then long breaks away from the systemic chemotherapy that we know is needed. And there's synergy between chemo and immunotherapy. So a lot of reasons to do a study with radiation rather than surgery. And now we have a study which is called ECOG acronym or EA 2183, and this is the clinicaltrials.gov number that you can look at this study. It's open across the country in the United States. And it's for patients with oligometastatic disease. Again, they have their own criteria listed here. You will note that peritoneal disease and brain metastases aren't allowed, but there's a list of criteria that you need to meet to be eligible. But if you do, and you've had at least 3 months and no more than 6 months of first-line chemo, any chemo, and not progression of the disease, then you could be eligible, randomized, and randomized to just continuing the chemo versus chemo plus radiation to the metastatic disease. And so this is a study that I think we all would emphasize to patients to consider if they're eligible. So I'm going to stop there. I know I've been yapping and it's already 1 o'clock, so we might have to do a separate talk on ESOPEC later. But let me address these questions. The first question is, would my single metastasis to the gallbladder count as oligometastatic on either or both criteria? If it's just one spot and it's on the outside of the gallbladder, that's typically considered peritoneal disease because that's in the peritoneal space. And so if you fell into the criteria after you had a laparoscopy and it didn't show any cancer anywhere else, then you probably fall into the criteria of peritoneal only and limited. But you may not qualify for, say, this ECOG acronym study, which doesn't allow peritoneal disease, for example. So you would be better suited for a peritoneal specific study that's looking at these types of things. If, on the other hand, it's spread to the liver, like near the gallbladder in the liver, then that's different, and that's a single site, single liver, and you'd be eligible under either criteria. Agree, disagree with my self-definition as oligometastatic. My working assumption is that even if not considered oligometastatic under either criteria, status is still effectively oligometastatic, especially since my affected gallbladder was removed with good margin. Yes. So yes, the answer to that is yes, and brings up another important point and a common question is, there's two things to say. First, I'll address your first one, and that is, yeah, I mean, you're considered essentially oligometastatic. There was just that one site, and whether you don't technically fit into these other studies, it doesn't matter. You were addressed and you're treated clinically like you were, and the good news, it sounds like that everything's gone and not back, so that's good. The second thing that arise that made me think of something here was that a lot of patients ask, well, what if I wasn't in the criteria when I was first diagnosed, but now I've had such a great response on induction chemotherapy that now I fit into oligometastatic disease criteria because a lot of stuff has disappeared. Those patients weren't eligible for this study. You had to be oligometastatic from the get-go. And that is another whole sort of scenario that we don't have answers for, and unfortunately aren't addressed in these types of studies. For me, as I like to summarize, is that I think that at first we need to be really super stringent in terms of who we're studying and assessing this for, and see if aggressive therapy works there. Because if it doesn't, then it doesn't make a lot of sense to make it more lenient, because it's probably not going to work in more advanced than if it didn't even work in the super, super stringent. But if it works in the super stringent, then you can start expanding and seeing like where's that threshold at which we stop losing a benefit. Okay. So, second question is it fair to say that curative treatment for stage 4 is up for debate at this point, and not entirely off the table? I'm glad you asked that. And so it's not entirely off the table. It's just a setback here that we have to be very wary about what we're doing, because as you saw, and has been my sort of statement all along at our meetings, is we don't want to do more harm than good by doing this, even though our intentions are good. We're seeing here what's happening to people, right? And so we don't want to just keep doing that. That doesn't make sense, right? But when we see like certain signals in certain subgroups, like lymph node only disease seems to consistently be showing some benefit, maybe, even though there's a detriment early on to some people that have post-op complications. That's where, we might still be, a little bit more aggressive. But this is sort of another plug, is to try and get on studies if you possibly can, obviously. But the problem with studies is that this is for newly diagnosed patients that fit all these criteria, and most patients don't. And a lot of our patients here have already, been on therapy for some time, so they won't be eligible for these earlier studies. So, there's never an absolute statement. Every patient is treated sort of like an individual with all of this other information that we know, and we apply it to you. And so there may be circumstances where we would still want to do something because X, Y, and Z. But, in general, I don't think it should be widely used, because we have like randomized study now showing that it's not effective, right? So, in your opinion, let's see, I would like to withdraw. Okay. Is your opinion, would HIPEC add to the surgery, make positives? That's a good question. So the question is, could HIPEC help peritoneal only disease? And so this study, Renaissance, wasn't asking that. They were doing just surgery and it didn't help. In fact, patients did worse. So we wouldn't recommend that, obviously. But nobody does that. So, if you're going to do it, you're going to get surgery plus the chemotherapy. So what my sort of statement there would be is, I would encourage it to be done in the umbrella of a study under a clinical trial where, things are controlled, we can follow it, we can assess what happened, and then at least we learn from it. And so, because a lot of patients are getting these types of procedures, and we're seeing here in this study, which, this has been going on for years, this type of an approach, but now we're seeing it's actually hurting a lot of people, right? So anyway, that's my opinion, which may be different from others. Is there a breakdown of age of patients with surgical complications? That's a great question. We don't know that. It wasn't presented yet, but these types of follow-up sort of results are reported at follow-up meetings, and so we'll learn more and more about this study, like how many patients got actually ablative radiation, because we don't know that yet, and did that help? And things like what you're pointing out, and there are other factors that affected post-op complications, age, other medical problems, et cetera, et cetera. So location of the tumor, location of the metastases. This is a really important question that we don't know the answer yet to. And then finally, it seems peritoneal disease is consistent in the exclusion criteria. Are there any trials looking at different interventions with peritoneal disease? Yes, the answer to that is yes. And that's a good plug here for me to remind me that as long as I talked about these two studies here, I've put on videos on the YouTube channel that are more detailed as much as I could be, and because I was no time constraint. And so I encourage you to go look at those, because I point out studies that are looking at peritoneal only disease, that are looking at HIPEC, And so there are a bunch of those that you could consider doing in the North America and Europe, et cetera. And so the answer is yes, there are studies looking at that. Next question, are there studies focusing on preventing recurrence in stage 2 and 3? That's a good segue to the third abstract, ESOPAC, but I know I'm already 10 minutes over, so I don't have a hard stop, and I could keep going for another 20 minutes to finish that, or we could do it another date. I might ask Aki and coordinators what their thoughts are on that.
I'm able to keep it running if you want to.
Okay. If patients want to stay or people attendees want to stay on, also I know that this is being recorded, so you can always go back and look at it. And also I've put on, as I mentioned, videos on Armani and videos on Renaissance in this past week on the YouTube channel. And I encourage you to see them, and also all the other previous videos that have a lot of information on all the different various questions that come up all the time. And then I have some presentations that still need to be recorded and put on that will be more detailed than the one I'm going to do now. But I will try and get through this now. And so I'll go through ESOPEC, and I got to thank you. So my pleasure. It's my pleasure to do this. So again, now we'll go back to our staging and our categories. And we're talking now about the setting of an earlier stage where stage 1 tumors, which really are localized, surgery alone is the standard of care. And in some cases, when it's really, really early, an endoscopist can try and scrape it off, endoscopic mucosal resection. However, a majority of our patients, especially with adenocarcinoma, fall into the stage 2 and 3 category, which is more advanced. The primary tumor is deeper into the wall of the esophagus or stomach, and or there's involvement in regional lymph nodes. Okay, so they have a higher stage, they have a higher risk of recurrence, and so we give what are called perioperative or adjunct therapies either before and or after the surgery to try and decrease the risk of it coming back with curative intent. Okay, so they're called locally advanced when it's a stage 2 or 3 cancer. Some definitions that you may hear about that you should know about when you're talking on this subject is neoadjuvant is referring to any therapy that's given before a planned surgery. So chemotherapy, immunotherapy, targeted therapies, radiation therapy would all be falling under neoadjuvant if it was given before a planned surgery. So even in the oligomet study, Renaissance, there was a neoadjuvant component of those 2 months of FLOT. And there was an adjuvant component of therapy after the planned surgery, even in the oligomet study, because it was trying to be treated as such, like a stage 2 and 3 patient. Perioperative can refer to like therapy at the time before after surgery, or it can mean you're getting therapy both before and after surgery with intention. And then you may also hear something called TNT, or total neoadjuvant therapy. That refers to the situation where a standard might be to give treatment before and after the surgery. But as we will point out here, and you even saw in the Renaissance study, that even though we're planning to give therapy after surgery, a lot of patients don't end up getting it because they're not well enough to. And so the idea is, what if we just put, instead of 2 months before and 2 months after, what if we just put all 4 before, and we'll get more in, and maybe that'll be better. Now, unfortunately, that study has not been done, and so we don't know the answer to that. We don't know if the component after the surgery is actually necessary to be after and not before. And others have sort of jumped to the conclusion that it must be better, we're just going to do it. So I know there's some heterogeneity. I know a lot of the patients on our calls get that. My practice has been, let's try and stick to the book, because this is where there has been a survival advantage. And I don't know about, if I remove this and put it in the front, if that could be detrimental or not. And so, there's no right or wrong answer right now, unfortunately. There is some evidence to suggest it, and I'll show that at the very end. We'll probably not get to it, but you'll see it in some of the videos I put online. Okay, so the idea of giving these adjunctive therapies either before and or after is to enhance the cure rate. And so this is going back 20 years now, called the MAGIC study. This was a study for patients with gastric and G-junction cancers that had stage 2 and 3 cancer. And at the time, in the late 90s, all through the 90s and early 2000s, the standard of care when you got diagnosed was, let's just do surgery and hope for the best. And as you can see, only a subgroup, like 25% of patients were cured with surgery alone. Most patients had a recurrence and ended up dying from their cancer. And so the question then was, what if we give chemo? Can chemo help in some way? And you can see that it did in a subgroup of patients. It cured an extra 10 to 15% of patients. Unfortunately, there were still patients that, despite getting the surgery, despite getting the chemo, they still had recurrence and ultimately died from their cancer. And so we have to acknowledge, though, that we have to give everybody the chemo just to save those patients that are here. Some patients are getting it and it's going to come back anyway. Some patients are getting it and they actually didn't need it. But we don't know who they are when we're starting out. If I knew who needed it and who didn't, it would be easy. We would just give it to who needed it. But we don't. And so we have to give it to everybody and hope that you're the one that's getting the benefit, right? So that's the concept of perioperative therapy. And this was the first study done in this disease to support that this is actually curing some people. A few things to know is that in some of the patients, it just delayed the recurrence, but they ultimately still came back. But for some, these 10 to 15% where the curves plateau, they're not recurring and dying anymore, that's now we can effectively say they're cured. And usually recurrence occurs within the first 3 years. That's where the majority of patients will have a recurrence. We never say never later on. There's rare situations. I've had patients 8, 9 years later, it comes back, but that's really unusual. Usually once you get past like the 3 to 5 year mark, you're in the clear, usually. Okay, so the other thing to point out is that these percentages are reflecting a very old study, 20 years ago, where we didn't routinely do PET scans for staging, we didn't do routinely diagnostic laparoscopies for staging, and we didn't have a lot of effective therapies in the stage 4 setting, all these new targeted therapies, for example, immunotherapies. And so survival across the board has increased. And so surgeries are being done better too. So everything's improved and all these lines are shifted up a bit, as you'll see as you go through the rest of the slides. But this was just to support the notion that if we give chemo, we can cure more people. And so we see that. But the lingering question that we always get with patients is, if you did surgery and you gave me all this chemo and you're doing scans and there's nothing there, how is it where is it coming from? How is it coming back? And so the answer to that is micrometastatic disease. Cancer cells that are so small that we just can't see them on scans, or the surgeon, when they're in there, they don't see anything problematic. They take out the primary tumor, they take out the lymph nodes nearby, whether or not they're involved with the cancer that just comes out with the surgery. And all of our scans show that everything else is great. But the problem is that these micrometastatic spots at the time you're diagnosed are already there and spread. And they can go to any of the known spots that this cancer can go to, listed here. And so despite all of our staging apparatus, it just goes under the radar and we don't see it. And I'll point out here that surgery is performed, but then over time, those micrometastatic sites have had time to double and triple and quadruple and get bigger. And then we can see them on the scans eventually, usually, as I showed you, over the coming months and years. I'll also point out that it should be obvious that the reason why we stage the cancers is because there is a higher risk of having micrometastatic disease the higher the stage. So the recurrence rate of a stage 3 is higher than a stage 2, which is higher than a stage 1, for this very reason. The risk of it having spread at the time you're diagnosed is higher if you're a higher stage. And so again, we give therapies, either systemic, which means in the IV, like chemo and immunotherapy, or we give localized therapy to the primary tumor and regional areas with radiation. These are possible therapy modalities. Okay, so the difference between systemic and localized therapy: systemic therapy goes everywhere in the body, like chemo or immunotherapy, and affects all the sites, including micrometastases. The idea there is to kill them off. Whereas localized therapy is focused just around the primary tumor and regional lymph nodes, like radiation. And so the goals are different with these two approaches. The goal of systemic therapy is, one, it can actually decrease the primary tumor size. And so the idea there is that we give it before the surgery to try and help the surgeon get it all out with a complete resection rate called an R0 resection. So it decreases a local recurrence. Similarly, radiation does the same thing, and it's focused on the primary tumor. But systemic therapy not only can kill off local micrometastatic cancer cells, but also distant ones that we can't even see yet. And the idea there is to decrease both local and distant recurrence over time. Whereas radiation therapy is just trying to kill off micrometastatic disease that might still be within the surgical field after the surgery is done, or to limit the local recurrence. The difference between neoadjuvant and adjuvant therapy, if you think of surgery as the main course, like I do, neoadjuvant's like the appetizer and adjuvant is like the dessert. And as I was pointing out, is like, do we really want to remove the dessert? And we don't really know the answer to that yet. I like dessert, but in this setting, I'm not sure if we can get rid of it safely. So the goals of these are actually quite a little bit different. The goal of neoadjuvant therapy is to, again, decrease that tumor size to enhance resection rates, so you can get a local, decrease the local recurrence rate, but also to kill off distant micrometastatic cancer cells even before you do the surgery. Get on those micrometastatic disease spots to try and kill them off and prevent them from seeding, to decrease distant recurrence. And a third component is that it can spare patients that have a really aggressive cancer that already has micrometastatic disease. And after 2 months, there may be new disease, new liver spots that we didn't know about, and then they grew through the chemo. So it spared the patient from an unnecessary surgery in some patients. And we saw that even in the OligoMets Renaissance study. On the other hand, adjuvant therapy, the dessert, now you've done your surgery, you're giving chemo after to kill any residual distant micrometastatic disease cells that might be present, to decrease distant recurrence, to kill residual local micrometastatic disease that might be there. And one of the things that we might want to know is, how do we know if this neoadjuvant therapy worked well or not? We can assess, the pathologist can assess the surgical specimen and see how much of the cancer cells are left or not. And that's called the pathological response grade. And that's shown here, where you can see that you can have a complete response, or you can have no response, and everything in between, and it's graded. And so you can imagine that if you have a complete response, you have a better chance of doing well than if you don't. That shows you that you have a more resilient cancer that might be more aggressive. So overall, though, survival is the most important thing. And I showed you a survival curve with the MAGIC study. But, usually on studies, you have to wait a long time before you get this information. And so we can use surrogates for overall survival that we learn earlier in the duration of the study, or while we're treating patients clinically. We have like the pathological response grade I just mentioned, but we also have disease-free survival, also known as recurrence-free survival or progression-free survival. So that's defined as the time point at which the cancer is not there present, the time at which we don't have any cancer visible on scans. And so this is the progression-free survival curve of that same MAGIC study. And you can see that if you don't have a recurrence by 3 years out, it sort of predicts what's going to happen, and that you'll probably still be alive at 5-year point. And so it's an earlier assessment, and we can say you're probably going to do well if you're still progression-free after 3 years. We also know the pathological response grade, as I mentioned. Patients who have a complete resection do better than those who don't. And then even before we get to the surgery, we have a number of things that we can test to see if you're responding to the therapy, which always predicts that you would be a higher likelihood of doing better than not. Okay, but the primary endpoint of phase 3 studies like the ESOPAC is always overall survival, sometimes disease-free survival. But these other earlier endpoints are usually exploratory endpoints in smaller studies to support going to larger studies like phase 2 studies. So then to summarize this, we can give therapy as a neoadjuvant, adjuvant, or perioperatively both. So that's adjuvant, neoadjuvant, or both. We look at various outcomes, but ultimately we care mostly about how long is survival better or not, and are patients free of cancer or not. So even though there's all these different ways of doing it, eventually what has emerged, especially in the United States, is that for gastric cancer, esophageal or G-junction adenocarcinomas, FLOT before and after surgery is a very well-established standard based on the FLOT4 study, but also for esophageal and G-junction adenocarcinomas, some prefer to do chemoradiation before the surgery, and that's it, and that's called the cross study. So this was a matter of debate for years in terms of which of these two is better. And finally, we have an answer to that, and that's the ESOPEC study. And I'm going to go through it real quick. The background is the FLOT4 study was better than the MAGIC regimen, so it displaced MAGIC and became the new standard for any gastric or G-junction or esophagus adenocarcinoma. But at the same time, the cross study for adenocarcinomas showed similar outcomes. But for those in the camp of FLOT is better than cross, like I had been and am, was that the FLOT study had more high risk cancer patients, more lymph node positivity, higher T stages, signet ring and diffuse type. So all like worse prognosis, and it still had similar survival. And this was being compared to actual chemo as the control arm, whereas this study was a little earlier and was comparing to just surgery, like just surgery, no other therapy. And so for me, it was always FLOT will be better. But in addition to that, chemotherapy, remember, it decreases the risk of distant metastases. And when patients do have a recurrence, it usually is distant. Less than 10% have just a local recurrence. And so the problem, obviously, is distant metastatic disease. And I've showed you that radiation doesn't address that. It's focused on the primary tumor. So for all those reasons, for all those years, I always debated and said FLOT was better, and that was my preferred treatment. And that's shown here that if you have a primary tumor here in the G junction or the esophagus, the radiation field is just there, in regional lymph nodes. It's not treating the liver or the lung or bone or whatever, whereas chemo is. And so that was the rationale. So really quickly now, the ESOPEC study, which was in the biggest session at the meeting, called the plenary session, because it is such a big, important study, because it's reassuring to people like me that always did FLOT, but it should be making everyone on the same page that FLOT should be preferred over cross. And so the results here is a head-to-head comparison. The inclusion criteria that was adenocarcinoma, squamous cell was not allowed. Gastric cancer, this was specifically for esophagus G-junction tumors, not gastric cancer, because FLOT is already a standard for gastric cancer. This debate was really for esophagus and G-junction. And the primary endpoint was survival with other important secondary endpoints. This trial was 438 patients that were enrolled. They were randomized, as we would expect with randomization. It equals all the different possible variables to the both arms. And this is the punchline, which in red is FLOT, in blue is cross. There's an absolute 5-year survival benefit of about 12%. So that's like 1 in 8 patients aren't alive anymore if you're getting cross instead of FLOT. And so clear outcome. And some of the other things to point out is that most patients started and completed the neoadjuvant therapy. Fewer patients in the cross group got all the chemo, which is not uncommon, but they almost all got all the radiation. And so this is common when you're getting cross regimen with weekly paclitaxel and carbo and paclitaxel. You might have to skip the 4th and 5th dose because your blood counts drop from the radiation and chemo. And then post-operatively, nothing's given in the cross group, but only about 63% of patients got any therapy after surgery, and just over half completed all 4 cycles. And then we always look at subgroup analysis to see, yes, it worked in the all-comer group, but what about all these different subgroups? One of the common complaints is, well, FLOT is too toxic for older patients, but a quarter of the patients were above 70 and the benefit was still there. The one thing that we do see is that low T stage and lymph node negative clinically disease seem to drive less benefit from the FLOT. And so for me, the question here really is, might a 2-drug regimen suffice for the more limited stage 2 patients compared to the 3-drug? And that's a future question that needs to be asked. In terms of progression or disease-free survival, the same thing was seen, that there was a clear benefit. So some patients are cured with CROSS, obviously, but more are cured with the FLOT. And so that's a 13.5% absolute disease-free survival at 5 years. So these are clear results that should end the debate, in my opinion. They point out, as we should always point out, is that adjuvant immunotherapy after completing the CROSS and surgery is now a standard based on the Checkmate 577 study, where you get nivolumab for a year. I'm going to show you my thoughts on that. But this study was started before that result came out, so they didn't have that as part of the CROSS arm. And similarly, there's been this push towards doing chemoradiation and in patients who have a good clinical response, not going to surgery and just following and seeing how things go and sparing them from surgery, which is a good notion. But these studies are not completed, and we don't know the result difference between adenocarcinoma and squamous cell. So this is not a standard of care yet. And so this is still a research question, because we don't want to be doing something that is worse than what we already do until proven otherwise. So otherwise, though, they concluded that this study showed that FLOT was better and that FLOT should be preferred over neoadjuvant chemoradiation CROSS. Just showing it again, there's a clear survival advantage for FLOT over CROSS, and so this should become a new standard of care for patients. Our NCCN guidelines as of yesterday, like this was done in April, show that CROSS is preferred as a preoperative chemoradiation or FLOT as a preferred regimen. I suspect that this will probably be removed and say this is an option, but only if you're not a FLOT candidate or something like that. And then you can see that nivolumab is recommended after surgery, postoperatively, in patients who got preoperative radiation. It's just a matter of time before phase 3 studies assess FLOT plus immunotherapy. We've already seen phase 2 data showing that it's better, especially in PD-L1 positive tumors, but it's not considered standard yet. Some of us in the US would do that for patients that have really high PD-L1 if we can get it. And also, I'll point out down here that if it's MSI high, it's already in the NCCN guidelines to get immunotherapy. And so, the argument that you should use chemoradiation pre-op so you can get the Nivo is a moot point, in my opinion. So I'm sorry I went over. That is where we will stop. I'm going to answer this one question that's here. Any news at ASCO 24 on the use of ctDNA tumor-informed method as a surveillance tool for stomach cancer? Any studies on percent risk with a negative ctDNA after 24 months of stage 3? Great question. There was no large-scale ctDNA result. Like, it would be great if this particular study incorporated that, and they may have, and we may see those results, at future presentations. The study started a while ago, though, before ctDNA was routinely available, especially like high sensitivity ones like, say, Signatera's. But this is a future question that will help potentially dictate who should and who shouldn't get chemo, how much chemo, is the amount of ctDNA in the blood identified or not. And if your specific question about ctDNA like 2 years after surgery, if it's still negative, that's a great sign. That's even more sensitive than, say, PET scan, CAT scan, and clinical assessment. And so if that's also negative, then as I showed you, that usually predicts good long-term survival. And then I got some thank yous. So it's my pleasure. And I will stop there. And again, lastly, go to the website for the Hope for Stomach Cancer. There will be a whole bunch of YouTube videos on each of these and more topics. And and with more detail for your questions. And of course, we have our patient advocacy groups that you can ask questions and follow up questions that arise there. So thanks again.